Vandana James ma'am, Reader, Department of Concern Endo, Tagore Dental College, to introduce the speaker of the day.
Thank you, Dr. Nisha. Thank you, the Mani team, for your beautiful presentation and giving an insight at what a great company and what all products you're offering to the field of dentistry. I thank you so much, Dr. Smita Singh, ma'am, our speaker for today, for joining us today. It's such an honor and privilege to have you with us, ma'am. Thank you so much. Ma'am has 20 odd years of experience in this field of dentistry and aesthetics. So it's a pleasure to have you with us. Ma'am is graduated from the King George Medical College, and she also did her post-graduation in this prestigious college. And she's been involved in academics, research, reviewing journals, PG training, and PhD program ever since. And as our principal mentioned, ma'am has been awarded the legendary Lady of Dentistry, Modern Dentistry, by the Indian Dental Association of Rajasthan. Commendable, ma'am. And ma'am was also got a district level award for excellence in dentistry by the government of Rajasthan, and many other such awards in national and international forums. I gather ma'am has also received an award for her oratory skills by the ex-president of India. It's such an inspiration, ma'am. And ma'am has been writing a lot of weekly columns in the daily newspaper, which is famous in Rajasthan as well. So, and it doesn't stop here. She is also an astute clinician who runs a private practice for more than 20 years in Udaipur and Rajasthan. And of course, she has numerous publications and research papers to her credit. And she delivers lectures frequently and also conducts workshops for both endodontics and conservative dentistry. So it's such an honor to have the legendary lady of modern dentistry with us today. We're really looking forward for this presentation. Thank you so much, ma'am, for accepting our invite and joining us.
Thank you so much, dear. Thanks a lot.
Yes. So can we go ahead with the presentation, ma'am? Is that okay, yes. Dr. Iman?
Absolutely, ma'am. Absolutely.
Okay. Okay.
Good morning, respected seniors and dear friends. Iman, am I audible?
Yeah, ma'am, very much.
Yes, ma'am.
And please let me know if the slides don't change or if there is any problem, please do let me know. So a very good morning to all of you. I bring my greetings from Udaipur. Rajasthan. I think all of you agree to this, that knowledge shared is knowledge gained. I am Smita Singh. First of all, I would like to thank Professor M. Mala, Chairperson, Tagore Educational Trust, Professor Dr. C.J. Venkatakrishnan, Principal, Professor Dr. S. Balagopal, Vice Principal, and Team Mani, Mr. Ritesh Sharma, Mr. Shivam Sahai, Ms. Iman Deodhar, Mr. Manoj, Mr. Ramajayam, and Mr. Vasantha for giving me this opportunity to be a part of this webinar. And thank you so much, Dr. Vandana, for the for your kind presentation. Today, we will discuss the simple and correct application of bonding agents, selection of composites in different clinical conditions, and restoring various types of dentine. So it is purely a clinical presentation today, purely a clinical one. This is my new clinic, which we opened just 6 months back. And so this is a corporate style clinic, and this is an academy attached to it, in which we take different types of courses. And this is my old clinic. Not the old one. I mean, this is my first branch. I just love working here also. And so as Dr. Vanna said, I am into practice since 1999 in academics and practice. So today, recent trends in posterior composites. So why do composite restorations fail? So many causes: poor hygiene, lack of salivary flow, high keriogenic diet, grinding in bruxers, material handling improper, insufficient depth of cure, and polymerization shrinkage, which is the biggest culprit for composite restoration failure. So excuse me, is there some problem? Is there any problem? Can you hear me?
Yes, ma'am, you're audible. You are.
Okay. I thought someone was saying something. So,
No.
So the first thing to go ahead with composites is that your case selection should be absolutely proper. So where should you not place direct composites? So first of all, direct composites should not be used in extremely hostile environments. That is where there is very high caries rate, such as in this case. What a high caries rate over here. Do not use composites. Large class 2 restorations where loss of contact is high and proper proximal contacts are difficult. Like here. Can you see such a broad contact? Is this contact good? No. Deep subgingival margins, like in this case, just see these deep subgingival margins which lie on cementum. Although deep margin elevation can be done in some cases, but remember, my dear friends, that do not use composites on cementum because composites leak like sieves on cementum. So GICs and indirects, that is inlays, onlays, work best here. Always avoid composites in bruxers. Now the state-of-the-art cavity design. So what is the changed cavity design for composite restorations now? First of all, the state-of-the-art preparation design for composites is excising the decay only. Preserve as much enamel as you can. You know, preserving enamel is the key. And one thing which you have to remember, friends, is that on enamel, composite does not need much thickness. 0.2 millimeters of thickness is enough. But on dentine, composite requires at least 1.5 millimeters of thickness. So, like here, in this case, this is an occlusal facet, and this occlusal facet is surrounded by enamel. So, even if you give less amount of composite, this will really work very well over here. But what about an occlusal facet, which is in dentine? If you give only 0.2, 0.5 millimeters, you don't prepare that facet, and you don't give a bulk of 1.5 millimeters in dentine, your restoration will chip off. Now you understand why restorations chip off if they are only in dentine, surrounded by dentine all over and no enamel. And the second thing is, always remember to make 2 class 1s if they are present in vicinity also, which means that all the intracuspal tooth structure should be preserved, because this is the new recent advancement of the dome concept of enamel. That is, just like churches have dome, cathedrals have dome. So that is, enamel gives the most strength to a tooth structure. So preserve enamel as you can, and the cavity design should be minimally invasive. And that is what is minimally invasive dentistry all about. So my dear friends, it's not the filling that matters, it's the prep that matters. So remember this fact. Now, for good adhesion, what do you need? Close contact must exist between the adhesive and the substrate. So what is the substrate here? Enamel and dentine. So remember this, that the surface tension of the adhesive must be lower than the surface energy of the substrate so that it can intimately contact or wet the surface. So you can't change the adhesive. You've got it in a bottle. You have to apply that. What can you change? You can change the substrate, which means that you can increase the surface energy of the substrate. So remember that teeth should always be pumised before bonding. Bonding on ground tooth surface increases bond strength, especially for self-etch adhesives. Proper isolation under rubber dam is a must. So the take-home messages for good for increasing the surface energy and for bonding is that bonding should be carried out in sound tooth structure only. Sound tooth structure. Remove all infected dentine. If you have to leave affected dentine, that's fine, but not infected dentine. Preserve as much as possible enamel on cavity margins and make sure your curing light is effective, because if that is effective, then only the monomer will change into polymer. Now, reasons for composite restoration failure. Why do composite restorations fail? If there is any remaining soft carious dentine, if you've etched for longer periods of time, if there is void in the first layer of composite, isolation issues and improper curing. Now let's see that all these factors, how you clinically assess the composite failures. When you leave this soft caries dentine, which is remained, and you've not removed all of it, what can happen? Marginal staining, micro leakage, secondary caries. That's right. If you've etched for longer periods of time, what can happen, friends? You know this, post-operative sensitivity. If there have been voids in first layer of composite, remember this internal gap over here. Isolation issues. If you've not properly isolated, then all this can happen. Whatever is written over here can happen. Improper curing. If you have not cured properly. So post-operative sensitivity is the biggest reason, and enamel cracks, because there's a lot of polymerization stresses. The residual monomer, which will leach over a period of time, is bound to give enamel cracks. So all etching techniques, let's introduce the recent etching techniques as well as all of them. So the first etching technique was the total etch, in which the etching was done on enamel as well as dentine. On selective etch, which is one of the most preferred techniques now, wherein you etch only the enamel and not the dentine. And self etch, wherein you don't use the phosphoric acid etchant, you just apply bonding agent on enamel as well as dentine. So when to total etch, selective etch and self etch? The problem does not lie in enamel, friends. The problem is in dentine. Why? Because the fluid is present in dentine. There is water which is present, and there is a lot of stimulation on exposed dentine, which causes fluid movements in tubules. So remember one thing. This is a clinical tip. Whenever you have to total etch, remember to do in the superficial layers of dentine. You can selectively etch in both the superficial, middle and the deep layers, and self-etching can be done only in deep or the middle layers of dentine. So this is what you have to remember always. Why is it so? It is because superficial dentine has dentinal tubules in the tune of 20,000 per square millimeter in number, and the diameter is 0.9 micrometers. And can you see, when the tubule diameter is less and there is less number of tubules present, so what happens? There is more amount of intertubular and peritubular dentine present for the bonding to happen, for a good bonding to take place. In middle dentine, the number increases and the tubule number is 29,500, but the diameter also increases, which means that the peritubular and the intertubular dentine amount is lesser. And in deep dentine, can you believe, the dentinal tubule number is 45,000 per square millimeter, and the diameter also increases 2.5 millimeters. And just see, can you see any much intertubular dentine present? So remember not to etch here at all. If you etch in deep dentines, you are going to harm the pulp, because these open dentinal tubules will lead the phosphoric acid inside the pulp. So, my dear friends who are using dentine etching, I just want to give you a tip. The recent advancement on etching time on dentine demineralization. This is a recent advancement, and the recent researchers confirm that if we etch for 15 seconds, the dentine demineralization is 3 to 4 micrometers. And the adhesive also penetrates to the same level only. but I'll take a pointer. Excuse me. So but if you etch for 30 seconds, then the dentine demineralization is for 7 to 8 micrometers, my dear friends, and the penetration of adhesive will only be till this level, 3 to 4 micrometers. What about this area, which is open yet vacant, where there is no adhesive present? So what will happen? So this unsealed dentinal tubule will permit dentinal fluid flow during thermal and tactile stress, which will in turn stimulate the nerve fibers in the pulpal tissue. Thus, stimulation is the primary source of post-operative sensitivity, and the patient will experience pain while eating or drinking hot or cold, or when just simply biting on restored teeth. So always remember that the etching time for total etch technique, if you use the enamel, is 15 seconds and the dentine not more than 15 seconds, and in any case. So when rotary instruments cut dentine, smear layer is formed, which is 1 to 5 microns thick. It has hydroxyapatite crystals from enamel and partially denatured collagen from dentine. So evolution of dental adhesives is based on this smear layer. The earliest generations of adhesives tried to chemically stick to it. The 4th and 5th generation adhesive systems recommend removing it, and the latest ones that we are going to talk about today is 6th, 7th and the 8th adhesive systems incorporate it into the bond. So let me introduce the self-etching bonding system, the money bond, where to use selective and self-etching adhesives. My dear friends, if you're currently using total etch products and still you're having sensitivity, if your sensitivity seems to be focused primarily on posterior composites, if honestly you don't see yourself using a rubber dam. If the majority of your preparation is in dentine, remember this. And in challenging cases, you should be using self-etching adhesives. What happens over here? Etching, demineralization and infiltration of primers all occur simultaneously. Smear layer and demineralized hydroxyapatite become incorporated into the bond. So this is the money bond, which is the 7th generation bond, very fast, easy, long lasting. This is what you need, a single coat application, and it also avoids pooling, because this is really frustrating. If the bond is viscous and goes and pools everywhere, it is impossible to get a good film thickness. And the best part about this bond is that it's a mild etch bond, wherein the pH value is more than 2. So gentle etching, so also reduces risk of post-operative sensitivity, and such kind of bonds which are gentle etching can be used safely in deep dentine. The bonding strength to dentine is 26 MPa, and of course the enamel is great. So how does this bond works? Let's see this. So my dear friends, when money bond is applied and allowed to dwell for 20 seconds, what happens? This smear layer is solubilized into the dentine, and this adhesive and the acidic carboxylic esters demineralize hydroxyapatite and carry the adhesive down into the exposed collagen fibrils into the open dentinal tubules in this peritubular dentine and also in the open dentinal tubules, which comes in contact with the etched intertubular dentine also. This adhesive comes in contact over here. So remember, after application of bonding agent, it should be left in the cavity for at least 20 seconds. Now you understand why this time is so crucial and so important. And what do? We apply the bonding agent and we cure it. We've missed all these steps. Your restoration will fail after some time. If not tomorrow, then after a few months or years, but it will fail definitely. So it should be left undisturbed in the cavity for at least 20 seconds. This has to be left undisturbed. Otherwise, there are many self-etch adhesives which need scrubbing, rubbing. So you have to read the manufacturer's instructions to go ahead with the bonding system that you are using. This is the minimum amount of time that the material is required for optimum etching and absorption. Now, steady stream of air is applied on the surface until rippling motion of the adhesive ceases. Why is this step important? Because this is the time that the solvent is being evaporated, whether it is alcohol, acetone, whatever solvent is present, has to be evaporated. Otherwise, it will interfere afterwards, create post-operative sensitivity, and also the solvent will cause the white line. The solvent is responsible for causing the white lines of your restoration. So now the light can be applied, the LED light preferably, which has the light intensity of more than 1000 to 1200 milliwatt per centimeter square for 10 seconds. And you are done. So my dear friends, all the steps that I stated are important for any self-etch adhesive, and it can be cured. So proper evaporation of solvents, steady stream of oil and moisture-free air. That's a catch, oil and moisture-free air, because the compressors that you are using, ensure that your compressors don't leak oil or moisture until rippling motion ceases. So once the rippling motion of the adhesive ceases, you are now ready to cure the adhesive layer. Now, when you follow the steps correctly, you form a very strong hybrid layer. Why do you need a strong hybrid layer? Is because this is the first layer on which the first increment of composite comes in contact with. So when the composite, so what happens when the first layer of composite comes in contact? What happens to this hybrid layer? This composite, when it is cured, so the monomer of the composite changes into a polymer. As a result, there is polymerization shrinkage because the monomer chain, monomer chain is longer. So when it cures, it polymerizes and the chain shortens. So when this polymer is formed with a shortened chain, there is shrinkage, which is called as polymerization shrinkage. And this produces stresses, which is called as polymerization stress. And where does all this stress go? On this hybrid layer, my dear friends. So this hybrid layer has to be so strong to take the polymerization shrinkage stresses. So now you understand why we are emphasizing on all these steps to form a good hybrid layer, so that this layer may not fracture and give a very good a foundation to the entire structure which you are now going to build. So the take-home messages for Money Bond is, it shows sealing ability of dentine reported to be excellent, should be taken in a Clix dish and used within 3 minutes. Sorry, should be applied on ground surface. Remember this, self-etch adhesives work best if they are applied on ground surface. The other uses where this can be used in luting indirect composite and ceramic restorations, and also repair of fracture composite restorations. Now the 7 mortal sins of adhesive technology which you are not going to practice. Number 1, disregarding the directions for use. Yes, read them. Contamination. Do not use adhesives in case of contamination of cavity with blood, sulcus, fluid or saliva. This is a big no-no. Over etching. Don't do that. I told you why. Over drying with a blast of air or dentine dehydration. Don't do this. Why? Because if you do this, then the dentine collagen fibers will collapse. Then where will the bonding agent go? Insufficient rinsing of the dentine conditioning, because the phosphoric acid should not remain in the dentinal tubules so that it may do harm later on. No usage of expired materials. No, not at all. Insufficient amount of adhesive should not be used. Remember the painter, how he paints your walls. Copious amount of adhesive should be taken to coat all the dentine and the enamel walls. So art and science of various direct composites. What to check when you buy a composite? First, the chemistry, that is whether It's a hybrid, nano-hybrid, micro-hybrid, microfill, nanofill, packable. Which composite do you want to choose in which condition? Physics. You should know the physics of your composite. Filler loading, elastic modulus, how the coefficient of thermal expansion, and so compressive stresses, tensile stresses, that it should match well to enamel and dentine, so that there should be a no mismatch. Biology, that is the polymerization. Shrinkage, your composites should show the least amount of shrinkage. All composites shrink, but then you have to select with the available the best one. Mathematics, how costly or cost effective it is, time saving, and patient should also be gained by it. I'm so sorry. So your composite should not slump, tear, pull, or stick to instruments. Remember this fact. Your handling, if you want to handle it well, you can take an alcohol swab, an alcohol gauze, and you can wipe your instruments clean and then start using them. This is the LM Art composite instrument set, which I really like. Durable. Your composite should be durable and give you a good restoration longevity. So for that, if you're using high quality composites, they show radio opacity. That is how frustrating it is, my dear friends, to do a restoration and not be able to see it on the radiograph. So select and pick only those composites which are radio opaque. Thorough cure. This also greatly contributes to the longevity. Your curing light should be absolutely great. Don't go for cheaper curing lights because they do not have collimation. They don't cure up till the needful amount. And you need a good curing light so that it can easily cure all the photoinitiators, no matter where they are located in the mouth. And they also help ensure restoration, durability, and longevity. No guesswork out of shade matching. Your restorations, your composite should have a chameleon effect, right? So that it can take up the shade of the adjacent teeth, and it should have a great high range of option to give you a good lifelike, detailed, aesthetic final result. You should have opacity of the dentine shade in combination with translucency of the enamel shade. And if you use a single shade, you can use it on a small chipper defect or multiple shades for a complex restoration. Your composite should be fluorescent. That is, if you go to a disco, it should not be like that your tooth disappears. Oh, no. So you need your composite to be versatile. It should perform well in anterior as well as posterior restorative case, and should also behave in such a manner that if you do both anteriors and posterior with it, so you have less inventory and less expired materials. It should behave well in anterior teeth, give a good, beautiful result, and also good mechanical properties, which means that mechanical properties along with aesthetics is what you need from your composite. So clinical indications, which composite to be used, although I am talking about this in the entire seminar, but just a little bit information that microfills, if you use microfills, then you should use it only as an enamel replacement in class 3, 4 or 5 restorations. Minimal correction of tooth form and localized discoloration can be sorted out with microfill composites, but they will not give you strength. So do not use them where you need strength. Hybrids you can use for all posterior restorations, but they do not give good aesthetics. So that is why the newer composites, the micro hybrids and the nano hybrids provide all of this. Posterior and anterior direct composite restorations, the micro hybrids can be used for veneers, the nanos also, and correction of tooth form and discoloration. And especially if you need color correction, micro hybrids is the composite of choice. If you're using packable, remember they'll give you strength but not aesthetics, can be used for posterior resin-based composite restorations, and flowables can be used in the pit and fissure restoration and can also be used as liners, can replace dentine. So selection of posterior direct composites, flowable composites. Let me first talk about this. What do flowable composites do? They have a good high wettability of the tooth surface. So this ensures penetration into every irregularity and their ability to form minimum thickness. So this also improves the removal of voids. And this is what you need for your composite restoration, my dear friends. You don't want voids in that to give you a weak restoration. They are also very flexible, so they can be used in undercuts as well. Now, if I introduce a flowable which is also viscous, that is the Flow V. So this is a great composite which goes and adapts nicely to the walls, can be used as a lining or base, can be used to fill undercuts, in tunnel preparations, which we do very often, fissure sealing, minimal invasive restorations, and class 5 restorations. This flowable with viscous is the Flow V is the composite of choice. The best part is that it is very strong, and you need a flowable that is strong because all the flowables that you have are not strong. Although they are flexible, but they don't have strength. This one has a good strength because of the filler content. The tensile strength is 46. The compressive strength goes to 431 MPa, which is quite good. And also remember the radio opacity is 210%, which you need for your composites. And depth of cure is 2 millimeters. So you should not take this composite more than 2 millimeters of depth. The shades available are so many. The polymerization time is 40 seconds for a 2 millimeter increment. Remember not to take the increment more than 2 millimeters. Now we are going to start with the restoration. But before you start any restoration, this tip is for all the composite restorations that you are going to use, wherever they are. The patient comes to you with a lot of stain, and what do you say? Oh, you have a lot of coffee, you have a lot of tea. It's not that, my dear friends. It's not because of coffee or tea that you've gathered stain. The patient has gathered stain on his teeth. It is because when you started doing this restoration, there was a lot of biofilm on the tooth, which you never removed and did the restoration on top of that. And this is what you get. So what should you do before starting any restoration is first check the plaque level. So this is a BioClear dual color disclosing solution, which I use, and I'll show you a short video how to use that. So isolate your teeth under rubber dam, eversion of rubber dam, and these are visibly clean teeth, isn't it? But let's see what happens when we apply the disclosing solution. So after the disclosing solution is applied, it is left for a few seconds and then rinsed off. And you can see the biofilms present as two colors, which I will tell you now. The purple and the pink. If you have a sandblaster in your clinic, sandblast this, remove all this biofilm which is present. If you don't have a sandblaster, you can use your ultrasonic scalers. They also do a good job. But you know where to use them now, isn't it? So this is how you can remove the biofilms. Now, what I want to tell you is that visibly clean teeth do not ensure plaque-free surface. Do not judge the book by the cover. So BioClear disclosing gel applied, and new biofilms stain pink and the old ones stain purple. New biofilms means which have been formed in days and weeks, and old, do you know that? Old stains purple. Old biofilms have been formed in months altogether. So when these biofilms are left on the tooth and you do a restoration, you can imagine the kind of bacterial level that the tooth surface has and which it is going to impart to the restoration. So after scaling or sandblasting, you are ready to start with the composite restoration. So let's do this pit and fissure with a flow V. So after the disclosing was used and the biofilm eliminated, and I have done this in all the cavity preparations and all the cases that I'm going to show you, but I'm not going to talk about it now because now you know that the first step is this cavity preparation, and this is the final restoration with flow V. So before and after. So the take home message is both flowable and viscous. This flow V is excellent for class 5, class 1 restoration and also for liners and bases. It is based on non-dripping technology, that is NDT. So what happens is that most of the flowables which keep on dripping after you've used them, this one does not. So it's really great to use it, that you use this flowable, keep it, and it does not drip on its own. Now, what about the polymerization shrinkage that we are talking about? So I talked about this, that the monomer has a longer chain, but the polymer has a shorter chain. When this cures into a polymer, this has a shorter chain. And because this has a shorter chain, so because of the shrinkage of monomer to polymer, there is polymerization shrinkage, which is the most frustrating part of the composite restoration. And till today, the biggest reason for composite failure. So let's manage this polymerization stress with bulk composites. Introducing Money Bulk, which is a bulk fill composite, can be used in posterior restorations, very simple and fast. This material is also flowable and viscous. How come it becomes fast is because the depth of cure is 4.5 millimeters, which means that you can, like flow V, you should not take more than 2 millimeter in one increment. And here with bulk composites, you can take them in a 4 millimeter bulk increment. So your technique and your time is fast, and you are able to complete your restorations in a limited amount of time. The total filler content is 77% by weight, which is great. Compressive strength is very good, and the radio opacity is also very good, 210% again. The depth of cure is 4 millimeters. It comes in a universal dentine shade, wherein you can, it has a chameleon effect. And because of this chameleon effect, it can very well adjust to the shade. But yes, all the bulk fills have this problem of being a little translucent, and that is why they have very good degree of polymerization and therefore less polymerization shrinkage because of being translucent, so that the light can pass through the layers of this composite. The polymerization time is only 20 seconds for a 4 millimeter increment. So imagine how less a time to do a restoration. So let's do this bulk in a fissure and see the cavity prepared. Selective etching. I am very fond of selective etching, and so in 80% of the cases I do selective etching. Only in those cases which are in enamel and superficial dentine, I use total etch. So after bonding with Money Bond, I used Money Bulk for cusp buildup, and this is the time you can put tints also in your surface. But remember one thing, my dear friends, this is a great tip clinically, is that tint should always be covered by composite. You can then put another layer of Money Bulk and cover it. So all tints, whenever and wherever you use, should always be covered by composite. And this is the final result. And this case is a class 2, but I did it with bulk, and see this. This is the pre-operative, this is the post-operative, but also see it on the radiograph. You can see a great contour and contact, and plus you can see the radio opacity of the restoration, which is the best thing of all money composites. So the take-home message for bulk fills are, because they are more translucent than other restorations, which allow the light to get to much deeper layers. And because of this, you get a good marginal seal. Why? Because the polymerization shrinkage is less. And also a very good depth of cure. Closely simulates the dentine of natural tooth structure. And because of great strength, they can be used in high stress bearing areas. So, dear friends, the bulk can also be used in high stress bearing areas, and the composites which I'm going to introduce now, the micro hybrids, also closely simulate the dentine. I told you that bulk have a chameleon effect, and so they simulate dentine, but micro hybrids have good opacity. And because of greater opacity and higher strengths, micro hybrids are perfect for supporting the high stress bearing areas. And also one more thing, if you want extreme color changes in your restoration, go ahead with micro hybrid composites. They give a very good result. So microhybrids can be used both for anterior as well as posterior restorations, can be used in class 1, 2, 3, 4, 5. You name a cavity, and it can be used also for indirect restorations such as inlays, onlays, laminate veneers. You can prepare them with microhybrids and cement them. Splinting loose teeth gives a very good result in them also, and adjusting the contours and shades, as I told you, to improve aesthetics. Microhybrids are the composites of choice. So I am also telling you the composites where to be used and in which clinical condition. This has a great compressive strength, 403 MPa, so that is why it has a packable consistency, but it also can flow under pressure. So there is intimate adaptation to the cavity floor. It is very biocompatible and gentle on gums. I have used them in class 5 restorations, because class 5 restorations are the most difficult ones because they debond so fast. But till today, no debonding with microhybrids have taken place. Although I will tell you how to do class 5s in the later coming part of the session. Has very good fluorescence, because this is what I was talking about. Your composite selection should be such that they give you very good fluorescent value as well as chameleon effect. It is available in a variety of shades. The curing time is 40 seconds and the working time is 2 minutes for a 2 mm increment. So this is the class 5. See how well it merges with the tooth, the rest of the tooth structure, and also very gentle and biocompatible on gums. So when we are talking about polymerization stresses, it is indeed necessary to talk about C factor, because this is what leads to polymerization stresses. And I'm now going to talk how to relieve these polymerization stresses so that less stresses are formed in your restoration. So what is a C factor? C factor is the ratio of bonded walls to unbonded walls, which means that if you have more bonded walls, you will have more C factor and therefore more polymerization stresses imparted to your dentinal or enamel walls. So needless to say that class 1 will have the maximum C factor, and the anteriors like class 4 will have the least C factor, and so that is why you have rarely experienced sensitivity with anterior restorations, but you do have sensitivity every now and then with posterior restorations. So introducing vertical incremental or the anatomic technique to do a class 2 restoration. When we know that when we put horizontal increments, this shrinkage of the monomer into polymer leads to polymerization shrinkage, which puts polymerization stresses on the adjacent walls. So how about not using this horizontal layering and shifting it into a vertical incremental layering technique, which creates a large free surface area with each increment. So you put an increment in a vertical fashion, you cure it, but the stresses do not go directly on the walls, but there's a large free surface area over here to release all the stresses from here. So there is large free surface area for the surface, for the polymerization stresses to be relieved. Another vertical increment, and again you have large free surface area for the polymerization stresses to be relieved, and so on and so forth. So in this way, the composite does not put pressure on both the tooth walls like in this horizontal layering technique. So this is what I'm going to talk about now. Step by step, this is a good video which I got on the net, and so I'm showing it to you. After the wedging and matrizing, flowable composite is being placed, and after the flowable composite that has been placed, you can nicely adapt it to the cavity walls and cure it. And after that, put the proximal wall with microhybrid because it will give you good strength. So microhybrids or nanohybrids for that matter can be used for building the lost proximal wall. Nicely adapt it to the cavity margins. This is the centripetal technique wherein you first build the proximal wall and then do the rest of the filling with the vertical incremental fashion. Now remove the wedge, the retainer, the band so that you get a direct access to the proximal walls. And now start building up with bulk composite or with micro hybrids or nano hybrids. So this is the time. You can also carve your composite. And when you carve, you also release stresses. So I would love to put bulk here. And then after carving, cure it. Put stains if you want a beautiful restoration. Lifelike, put stains. This is the time to put stains when the last layer of enamel is remaining. Cure it, and after that, now you can start building this lost enamel with microhybrid of a brighter shade to mimic enamel and start putting it, applying it in a vertical incremental fashion, cusp by cusp. That is why this is called as the vertical incremental layering technique or the anatomic layering technique, because very little post-operative adjustments are required for such anatomic techniques. You hardly need any post-operative adjustment because you have filled it in a very anatomic form and fashion. So keep placing in vertical increments. Build the composite cusp by cusp. And there is such a large free surface area available for the stresses to be relieved from. And at the same point, you can also carve. Carve the cusps, give it a good anatomic form so that very less adjustments are required later on. And when you put the last increment and cure it. You can also apply the glycerin gel and then do the final curing, so that the oxygen inhibition layer does not form and you get a very good final cure of the composite. So this was about the vertical incremental technique, and now I'm going to show you a case in which this was a failing silver amalgam restoration. So first I did the pre-wedging, and that was because pre-wedging also does not, it helps not to nick the adjacent tooth, and apart from that, it also gives a little bit of separation. So this is the money burr EX31, which is a very good burr for removing all the old fillings. This comes in extra shape and extra burrs section, special burrs edition. And after applying the rubber dam, the last increment should be done with a money carbide round burr. I am a great fan of this. Number 4 or number 5 in slow speed. Remember to remove close to the dentine the deeper layers with a round burr only, so that you may not do any harm to the underlying pulp. And also these round burrs can easily and effectively remove all the infected dentine. What kind of preparation to give for a composite restoration for a class 2 or class 1? Your preparation should have smooth line angles. Avoid unnecessary tooth structure removal. Remember, preserving enamel is the key. Don't forget this. As much as enamel that you can preserve, do that to give you a good bonded composite restoration. Beveled margins only in peripheral seal area, which is this. This is the peripheral seal area at the periphery up to the gingival seat. RMGIC liners to be given to protect deeper cavities. Selective caries removal. Remember to remove all the infected dentine, and you can leave the affected dentine if it is very close to the pulp. So this is the peripheral seal zone which I was talking about. See, it has been marked with this color. See this peripheral seal zone. This is the zone wherein no infected dentine or affected dentine also for that matter should be present. If you want a very good seal of your composite and you want the longevity of your restoration, remember not to have any infected dentine in this area. Get sound tooth structure in this peripheral seal zone. How do you do this to see whether any caries is left or not? All of you know this, caries detector, the dye. So when you use the dye and rinse it off, this is what you get. The infected dentine is darker red in color, like here, and the affected dentine is lighter red. So you can leave this affected dentine, but you have to remove the infected dentine. And how do you know clinically which dentine is it? So healthy dentine is hard, cannot be removed without a burr. What about infected dentine? Infected dentine is soft. Due to lack of mineral content of collagen network and collagen network, that can be easily removed by just gentle scraping. And affected dentine ki consistency is firm and leathery. Why? Because of the presence of mineral content. So here there was absence of mineral content in soft infected dentine, whereas affected dentine does have mineral content, and that is why you can leave it, because the pulp capping agents which you are going to use on them can form very good bonds. The hydroxyapatite and the calcium from the pulp capping agents can do a wonderful job of producing reparative dentine. So this is also a very good tip which I'm going to give you. Whenever you finish with your cavity preparation, remember to take a finishing stone and put it all around the margins. Work on the margins with the finishing stone. This lets the tooth restoration interface become just invisible. So this is a great tip which you can practice. So that we've seen the cavity preparation is okay. Now we go ahead with the sectional matrix system placement. The wedge has been placed and the sectional matrix placed. Selective etching. Selective etching, the peripheral zone area, you can see the enamel was present here, so that is why the etching is here. Had it been in dentine, the lower layers, no etchant to be used on dentine. Please remember this, my dear friends. So when you rinse this after selective etching, the frosty appearance of enamel can be shown. And can you see this? I'll take a pen. And you can see the frosty appearance all in this peripheral zone area and also on this enamel surface. Now this is ready to bond. So money bond applied. Gentle stream of air for solvent evaporation. Light cured. Now, since I have enamel, my dear friends, I showed you that I had enamel here. So that is why my choice of composite is Flow V or Money Bulk, right? But had there been no enamel and there had been only dentine, then my choice of material would have been RMGIC. So now Money Micro proximal wall build-up with centripetal technique. So this is the Money Micro building the proximal wall. The LM Art instruments, the condenser for contouring proximal wall and the applica for rounding it off from the margins. Sectional matrix and retainer removed because I told you that now you can easily do the curing from all the sides of this proximal wall from here, so that your light may reach the deepest part of the cavity. Why? I'll tell you now. Because as the distance from the curing light to composite on gingival box increases, the light intensity drops significantly, resulting in inadequate polymerization. So when you remove the matrix band and the retainer, the light curing can be easier for all increments. And do you know, my dear friends, that on the surface, your degree of conversion, that is degree of conversion means from monomer to polymer. 65% of the monomer changes into polymer. But what happens when you reach 4 millimeters down? That is on the gingival seat area. Only 15% degree of conversion, which means that you feel that you have cured, but actually most of the monomer has not been cured. And what will happen after that? After few months and years, this residual monomer is going to leach out. And therefore the degradation of the bond at the gingival area, and therefore the secondary caries, the marginal leakage, and all of this will lead to marginal deterioration and also debonding of the restoration.
Yes, ma'am. Sorry for the interruption, ma'am.
Yes.
Some of the participants are saying not viewing the slides, not being changes.
Excuse me?
Yeah, Balagopal sir and some of the others have said that the slides are not being changed.
Oh.
They are viewing the previous slides.
Right.
I'm just confirming from them which slide they are on.
Right. And can you see, Iman, can you see the slides changing?
Yes, ma'am. From my end, it is changed, and we are in line
Okay,
with.
so please ask sir. You are at Money Bulk?
Yes, of course. Balagopal
Yes,
sir
ma'am.
is saying.
Yes.
Right.
Yes.
So please ask sir that which slide is on and what should I do then?
Yes, he's saying that they are stuck on the slide of infected dentine and affected dentine.
Okay, I'll go back to that slide and then we'll ask sir whether now it is changing or not.
Sure, ma'am.
Okay. So sir, can you see this infected dentine slide now?
I can see that infected, affected, healthy dentine. Now it's changing. Tooth restoration interface becomes invisible.
Right, sir, right. right, so I'll come back from this. No problem, sir. So, so then this is the finishing stone to be used to make the tooth restoration interface invisible. So can you see now?
Yes, I can see that. Yes.
Okay, sir. Thank you, sir.
Thank you. Thank you.
So the sectional matrix system placed after removing all the caries in the peripheral zone, selective etching, and after selective etching, you remember, friends, only 15 seconds to be etched, not more than that, not even a second more than that. And here you can see the frosty appearance of enamel. And this is what I said, that you can see the frosty appearance on the surface and also on the gingival seat area, the peripheral zone. And here we have enamel throughout. In the peripheral zone, we have enamel. And this is now ready to bond. Money bond applied. And remember to follow all the steps which I told you for applying the bond. Gentle stream of air for solvent evaporation. Light cure. Now, because I have enamel here, so that is why I used a flowable composite. But if I don't have enamel here, then I will use a RMGIC. Or if I have a broad loss of contact, then I will go for indirects, or I will do deep margin elevation. So Money Micro proximal wall build up with centripetal technique. I'm going to use it. Use the rest of the filling to be filled with. And this is, I built the proximal wall with Money Micro. Adapted and merged. And these are the instruments that you can use. That is the LM condenser for contouring proximal wall and LM applica for rounding off. You can use any instrument that you are comfortable using with. And now I remove the retainer, the matrix. And why did I do so? Was that so that the light curing system could be applied on this buccal surface, on this lingual surface, and so that I can get a good degree of conversion. And because as the distance from the curing light to the composite and gingival box, the light intensity drops significantly, and this reduces this results in inadequate polymerization. So when we remove the matrix band and the retainer, the light curing can be easier for all increments. And this is what I said, that it is so strange that we do think that in most of the cases when you're doing a class 2, I believe the gingival seat is at least 4 millimeters down from the surface. And imagine the degree of conversion on the surface is 65%, the monomer being changed into polymer, and at the 4 millimeters level, it is only 15%. So, which means that we only think, this is wishful thinking, that we are thinking that this gingival seat restoration or the gingival seat material is polymerizing, but actually it is not. And when it does not polymerize, only 15% degree of conversion takes place. That is that 85% residual monomer is still present on the gingival box area. This residual monomer will lead to degradation over a period of time, which will lead to marginal deterioration, and after a few years, your restoration will fail. That is for sure. So after we've removed the band, the retainer, now is the time that you should take your light curing probe here on this surface, cure nicely so that this light can reach the surface where we intend this to reach. And if you want to use tints, then this is the time to use tint. And after using tints in a very minuscule amount, my dear friends, otherwise you'll get a very bad color. So the tints have to be used in very minuscule amount and always with a probe. The tine of the probe that gives the best tint placement. And after that, you can do the cusp build up with Money Micro in vertical incremental layering fashion. So this is the complete case, the occlusal anatomy, and see, after checking the contacts, we are finished with this. And now a second case that I'm going to discuss. Here, there are two class 2 restorations in the premolar and the molar after removing the carious portion. There's a question mark. So I did see what it was, and after removing this dentine, because this dentine is falling in my peripheral zone, my dear friends. It is coming in my peripheral zone over here. So I cannot leave it. This, you can see this this area which comes in the peripheral zone. So I can't leave the carious dentine over here. So I removed all of it with round burr and with hand excavators. And after this, now it is ready to be etched and bond. Selective etching and bonding first. And when you are doing two adjacent class 2 restorations, always remember, dear friends, to first to build one, remove the matrix band from there, and then you should build the other one. This is a good tip. And I always like to build the first one first and then go to the second one. So after that, you can again build it up after centripetal technique, follow the centripetal technique and build it up with vertical increments. And see the radio opacity of the restoration and the contact and the contour. So now let's talk about finishing and polishing. And I have a video to show. Let's see how to do finishing and polishing of the right. So this is the coarse discs. The first finishing protocol is to use the coarse discs, the medium, the fine discs, and this I have taken from 3M. These are the Soflex discs, and I know that all of you use it, and it really gives a very good occlusal adjustment as well as finishing. So they come in various grids. You can start with the coarse, go to medium and fine, and sometimes that would be more than enough. Now, but I have shown you all the steps so that you know everything, how to do the ridge and the occlusal. Finishing can be done with this finishing wheel, which is from Enhanced Tensply, and vary pressure for contouring and finishing. Not with the same pressure, you can vary the pressure for finishing and for polishing. And this is the finishing point again of Enhanced Tensply. This gives a very good occlusal surface finish. That wheel was for the margins, and this gives a very good occlusal finish. And this is the Magic Mix BioClear Pre-Polisher. Apply with soft finishing cup. This is a pre-polisher paste.
जरूरत पड़ेगी इसमें एंट्री करने की, ठीक है? तो मैं आपको फिर आप तैयार मेरे को पॉइंट्स आप दे दो और जिस दिन बोलोगे.
So just see the finish with the pre-polisher paste and a rubber cup. At any point you feel the finishing is complete, you can leave it. This is the Soflex spiral wheels from 3M, and this is the beige one, which smoothens and removes the scratches that develop during contouring, and this prepares the surface for high gloss polishing. So they come in beige and pink, white, sorry, beige and white. So you can use the superfine polishing wheel white, which creates a very smooth, high gloss polish, and it should be used without paste and water. So this is first the beige and then this white. If you feel you are done, you are done. But one thing which I like and I always do is buffing. And this is buff from Super Snap Kit. It is used in slow speed and low pressure. And this would be all from the finishing and polishing side. And at any point in time, you feel that after using the Softlex discs, your surface lustre, your restoration is smooth enough, you can go to this buff and finish it off. So I have showed you all the steps. It depends on you where to stop. So now I'm coming to the last leg of my presentation today, and that is solution to deep caries lesion. So my dear friends, what do you do in moderately deep or deep caries lesion? I told you how to check the consistency of infected and affected dentine, and after you've done that, you've removed the affected and infected dentine. Always remember how to do this in steps. First of all, use air rotor with copious amount of water. This is the key, copious amount of water, because you're very near to pulp, till 2 millimeters from pulp. When you come to the last 1 millimeter, you will ask, how will I know whether it is 2 millimeters or 1 millimeters? You will very well understand because you've been working. So your clinical acumen will tell you whether you are 2 millimeters or 1 millimeter. So in the last 1 millimeter, it should always be excavated with round burrs, as I showed you, in slow speed or with smart polymer burrs. You know about this. So you can also use smart polymer burrs. And after this, if you feel that there is still any affected dentine left, then you can take a excavator, hand excavator, and you can use that. After this, place a 2% chlorhexidine in cotton pellet in cavity for 2 minutes, so that this is a good antibacterial and bactericidal solution. And why are we talking about this is because now you know very well about the superficial dentine, you know about this middle dentine and deep dentine, you know about the number of tubules and the tubule size, the diameter, how it changes. So you have to keep all this in mind when you are doing your cavity preparation. If this was not enough, the biggest problem with dentine is the water, because in superficial dentine there is only 1% water, but when you reach the deep dentine there is 20% water. So this water is ready to do your bond, is ready to do bond degradation over a period of time, because this water will ultimately harm the bond strength of your restoration interface. And also don't forget the MMPs, which are there, derived from the dentinal tubule. So there is so much problems associated with dentine. Enamel is really sweet. It does not have any problems, and it just, is so, what do you say, so benign. So this is the deep cavity which we are going to restore. So after removal of the caries, can you see? Sorry. Can you see this area, which is a little deep over here? Now take a chlorhexidine soaked pledget and keep this cotton pellet in the cavity for 2 minutes. And after that, I recommend that you use, if ever you have any hue of the pulp, then it would be best to use biodentine, because MTA takes a lot of time to set. So probably you cannot do, if you place MTA, you cannot do the restoration in the same sitting. So it would be best to use biodentine, because this sets within 9, 10 minutes maximum. So take biodentine, place it on the pulp and or the area which you feel is deep. And after that, you can now place RMGIC on top of that, because biodentine, MTA, all of them are very weak. So you need to support them. And it would be best to support them with resin modified glass ionomer cement. So RMGIC can be used on top of that. And now once RMGIC sets, you can now easily selectively etch and rinse it with water. Nothing is going to happen to RMGIC. So after this step, you can do selective etching, and please do not etch dentine. And after this, bond and put proximal wall will build up with money micro, and then do the rest of the restoration with money bulk, and the last enamel layer to be again substituted by money micro. So this is the contact and contour of this restoration. So now what happens? This was about deep carious lesion. Now what happens when there is sclerotic or hypermineralized dentine or amalgam corrosion infiltration? Do you see, my dear friends, do you see this sclerotic dentine which is so hypermineralized? This is so hypermineralized, and not only hypermineralized, this also the dentinal tubules are partially or completely occluded. Now tell me, how will your bonding agent penetrate here? So a clinical tip, a good tip is that when you are dealing with sclerotic or hypermineralized dentine or such kind of amalgam corrosion infiltration dentine, it would be best to roughen the superficial areas of hypermineralized dentine, because this improves the survival rate. And the recent studies have proved this. Because previously what they used to say is that previously the studies used to show that you etch this sclerotic dentine for 30 seconds, and then apply the restoration. But now they say don't etch dentine, because as it is, it'll only create harm and it will not do any good. The bonding agent will probably not penetrate in that, but it can penetrate if you roughen the superficial areas of the hypermineralized dentine, and this improves the survival rate. And the same stands for non-carious cervical lesions, that is NCCL. What about tertiary dentine and transparent dentine? The same thing applies for this. The only difference being that in this dentine also, I would recommend to give a base of RMGIC and then do the rest of the restoration with money bulk, and then top it up the enamel layer with micro hybrids. Now, this here, this is a deep restoration which we are going to fill. My dear friends, can you please guide me how to do this? Because I have been talking all along, but now if you could tell me, because how to do this, because we know about dentinal tubules. We know that dentinal tubules in superficial have such kind of structure, When they go in deep, they have less intertubular dentine, and when it is sclerotic, it is like this. It shows like this in structure. But have you ever thought that in the gingival area, the dentine is lying like this horizontally? How will you be able to etch it? How will you be able to etch it? Because the dentinal tubules are not like this, so that you can form hybrid layers. It is lying flat. So my dear friends, I am going to give you the tip of my lifetime. What I have learned is, if ever there is enamel present over here, go ahead and do a flowable composite or a bulk composite. Right? Give the layer of flowable or bulk composite over here. And if there is no enamel, then what do? Then please do not use composites, because any etching, any self-etch adhesive, any adhesive will not work here, because this dentine is just impossible to etch. So best would be to give a liner of RMGIC over here just give this RMGIC liner here. And if you feel that this is quite deep, so you can also give biodentine and then give RMGIC as we discussed. And after this proximal area, this proximal wall to be built with, yes, please. What should I build it up with? I can build it up with either money micro or bulk. No problem. But I love to build it up with money micro or micro hybrid so that it may give me a good packable consistency. I can form my proximal wall very well here. Now the rest of the cavity easily can be filled with money bulk. This whole cavity can be filled with money bulk, and the topmost layer that is mimicking the enamel can now be filled by the micro hybrid. So this is, in a nutshell, the take-home messages for shallow or moderately deep cavities 2 to 3 millimeters below DEJ. Replace dentine by Flow-V and replace enamel by money micro or nano. But for deep or very deep cavities or post-endo restorations, which are 4 to 6 millimeters in dentine or maybe more, replace dentine by money bulk and replace enamel by money micro or nano. So how simple it is. So diamond and carbide burrs can be used for surface roughness. Try to keep large percentage of restoration margins in enamel, and bevels should always be given appropriately. And my dear friends, choose your materials wisely. In the end, remember, learning is work in progress for lifetime. So, you know, friends, what happened one day that a man feared his wife wasn't hearing well, and he thought she might need a hearing aid. Not quite sure how to approach her, he called the doctor to discuss the problem. So the doctor told him about a simple test to perform, and that evening the wife was in the kitchen. He stood about 40 feet away and in a normal tone asked, "Honey, what's for dinner?" No response. So he moves closer to the kitchen about 30 feet, then 20 feet, then 10 feet, and then repeats, "Honey, what's for dinner?" Still no response. Now he's really mad. He walks up right behind her and he asks her, "Hey, what's for dinner?" So the beautiful wife says, "James, for the 5th time I've said Matar Paneer." So my dear friends, the moral of the story is the problem may not be with the other person, the materials, the equipments, the composites, the bonding agents, the instruments, the patients, the attendants, as we always think. But it could be very much within us, isn't it? So no one can go back and change a bad beginning, but anyone can start now and create a successful ending. The sky is the limit, my dear friends. I am available at both these email IDs and my contact is this. If you ever want to contact me, please feel free to do so. And if you are visiting Udaipur, do also let me know if I can be of any help to you. Thank you so much, my dear friends. Thanks a lot.
Thank you, ma'am. Thank you for the wonderful and interesting lecture. Each information which you provided in your presentation was a wonderful clinical tip for us. It will be of an utmost help in our practice.
Thank you.
Thank you, ma'am. We have a few queries and questions from the participants in the webinar. So shall I come up with those questions, ma'am?
Why not?
Okay. So the first question was, can we use bioactive composites in case of class 2 caries extending below CEJ?
Why not? You can use them.
Okay. So what adhesive pH would you recommend on caries affected substrate?
What?
Adhesive pH, ma'am. pH.
What adhesive pH? Mild edge. Mild edge. This is what I talked about, this money bond. Mild edge adhesives.
Okay.
Yes.
So, and your
which
choice
have a pH more than 2.
More
which
than
have a
2.
pH more than 2.
Okay, thank you. What is the choice of matrix system which you use for your class group?
That's a good question. I use Palodent, Dentsply. I've been using that for time immemorial now since it was introduced. So I'm quite comfortable with that. But I also have Garrison. Yes. Yes, but Dentsply, yes.
Okay. And water-related hydrolysis or degradation of the hybrid layer has been a most common problem in case of your 6th generation single bottle and 7th. So how to tackle that clinically?
Oh, this is what I talked about. In the entire seminar, I talked about how to, form a strong hybrid layer so that it may not degrade, because that is not in our hands. There are MMPs that they will degrade, but then we
Ma'am, you went on mute, ma'am.
No,
No, ma'am, no.
I'm not on mute. So over a period of time, that the only thing that you have to learn is the correct steps to follow so that you build a strong hybrid layer.
Should we bevel the enamel at the gingival seat?
That's a very good question. Actually, there's so much of confusion in that, whether to bevel, not to bevel. But my take on this is that I usually don't bevel unless and until I feel that I want to improve the bonding at the gingival surface. Then only I bevel. Otherwise, I don't bevel, because previously the evidences were that we should bevel, but now the recent research, as all of you must have read, is that they do not advocate beveling. So it is your clinical acumen that when you feel that you need a more, you feel how that enamel is placed over there. Can you get a good bonding to that enamel? Then you don't bevel. But if you feel that you have less enamel, or the enamel is very friable or weak, then you should bevel.
Thank you.
Yes.
What makes Moni bond, that is Moni bond, different from that of the 8th generation in terms of composition? That is, the 8 bonding generation agents also has 10 MDP and 4 MET. This was the question.
So it is different in the sense that it is mild etching, number one. So it is a very good self-etch bond, because what do you want in a self-etch bond is that if you have to use it in deeper dentine layers, you can use it safely. So this is what makes it very different from the other bonds.
And your opinion on 1 second and 3 second curing units with high intensity?
Oh, yes. I have a very bad opinion on that, because I would always want to first soft cure, right? And then go in a ramp manner, or the normal curing. But I never recommend the 1 second and the 3 second. I mean, you really need to give a pre-gel stage for some time so that the stresses are relieved from the composite, isn't it? That is why you have failures. So actually, because of lack of time, I could not cover the curing section. Otherwise, I would have talked about this. So yes, my opinion on 1 second and 3 second is not good. I would never recommend that.
Okay. So that's
Yes.
all with the questions. So thank you for your...
Oh, that's so nice.
Thank you for patiently answering all those, ma'am. And then it was a wonderful